Perfect. Good to see you.
Good to see you, Dr. Pritz. Thank you for joining.
12 o'clock. Jose, doing to start?
Sure.
Yes.
I can welcome and then defer to both of the moderators, Dr. Alan Guo and Carlos Mendoza. My name is Jose Pascual. I'm from Philadelphia. I want to thank Antonio Matos, who's been doing the PTS International Case Conferences for over 10 years, 14, 15 years. And now the AAST has the privilege to join the PTS once a month. And today is a joint session. And we have wonderful presenters from across different parts of the world. We are also privileged to have our Taiwan contingent who's speaking to us from the middle of the night. We're very appreciative. And so I will defer the rest to Drs. Go and Mendoza. Gentlemen.
Okay, good afternoon, everyone. Thank you for joining this AAST PTS Virtual International Trauma Case Conference. Just a quick reminder for the presenters. Before you share your management plan, please pause and give the panelists a moment to weigh in on imaging choices, potential surgical needs, and some other treatment options. And also encourage a rich discussion and share learning. So each presentation should be kept under 25 minutes, which includes time for question and panelist input. To stay on track, we kindly ask you to avoid literature review, no literature reviews, and no guideline summaries. And I'm honored to be co-moderating today with Dr. Carlos Mendoza. Our esteemed panelists today are Dr. Timothy Pritz. He's a professor of clinical surgery at the University of Cincinnati, and Dr. Mayane Nguyen. He's the head of trauma at Charlotte Makeke Johannesburg Hospital and professor and academic head of surgery at the University of Witwatersrand. And we also have Dr. Juan Carlos Salamir, who is a professor of surgery at the Universidad del Azuay, Ecuador. So without further ado, let's begin our first presentation by Dr. Yuhao Wang, who is an attending physician in the Division of Trauma and Acute and Emergency Surgery at Chang'an Memorial Hospital in Taiwan. Dr. Wang.
Okay, thanks, Chairman. So let me share my PowerPoint. Okay, so good afternoon, everyone. First of all, I'd like to thank AAST and SPT for inviting me and giving this opportunity to share this interesting case at the International Trauma Case Conference. I'm Wang Yuhao from the Department of Trauma Emergency Surgery at Chang'an Memorial Hospital in Taiwan. So let's get started. So this is a 62-year-old female with no known systemic disease. Her chief complaint was left hip and lower back pain lasts for about half an hour. This case actually didn't occur on Taiwan's main island. It happened on a small island close to China, one of the Taiwan's offshore island, a small island that's about 14 minutes flights away from Taiwan. It's called Kinmen Island. The injury mechanism of this case occurred on the morning of January 7th, involving a car-to-car collision. The patient was a driver of one of the car, and her bicycle was struck by the side by another car. Initially, she experienced loss of consciousness with some abrasion and laceration noticed on her face, as well as abrasion on her left hand. During transport, she complained of chest and lower back pain, but remained hemodynamically stably throughout. The ambulance crew performed basic wound care, and she was then transferred to the local hospital, Kinmen Hospital. And the patient arrived at Kinmen Hospital Emergency Department at around 8 a.m. or 8 o'clock on January 7th. Upon arrival, her vital signs were relatively stable. Her primary complaint including left hip and lower back pain, headache, and left lower chest pain. According to the EMT description, she initially had a period of loss of conscious, though the exact duration wasn't clear. On arrival, we performed initial trauma assessment based on ABCD survey. The airway, the patient was able to speak clearly without complaint of any neck pain, and there was no obvious oral nasal bleeding, so the airway seems to be fine. And the breathing, she appeared mild dyspnea, but because of pain, but we weren't certain if there was any decrease in breathing sound according to the medical chart. And circulation, her pulse rate was 95 beats per meter and the blood pressure was 102/66. There was no obvious active bleed, wound, or any long bone deformity. And this disability, she was fully conscious with clear awareness, and both pupil was equal and related to light. And exposure upon examination, there was no obvious external wound or long bone deformity noticed. So after the initial this information, what the next thing we should do now? So after complete the primary survey, I think that yes.
I'm sorry. So just have the panelists to have some comment here. So Dr. Pritz, at this point of time, what would your priority? Now we're talking about ABC, and some people talking about CAB. What do you think? What should we do at this point?
Yeah, just sort of thinking out loud, whether you look at ABC or CAB, it all really looks intact and your primary survey is intact. So vital signs are reasonable for your situation. And I'm sort of thinking out loud, I'm thinking could be some element of a head injury because it had a concussion. And if I'm worried about, left hip and lower back pain, I'm thinking, skeletal pain or skeletal fractures, specifically pelvic fracture, hip fracture, maybe neck of the femur, maybe sacrum, all potentially injured. With the lateral impact motor vehicle crash, also worried about soft tissue injury, specifically, liver and even aorta if there's enough impact to cause an aortic stretch injury. So, at this point, I would proceed with my secondary survey and thoroughly evaluate the patient. Oh, there's a note there in the chat in Taiwan. People drive on the right side of the road, which is very helpful. But would still, be worried about, injuries internally. And at this point, would move on to the secondary survey.
Dr. Moon, what do you do in South Africa?
Yeah, I think what has been said, we would also endorse. This patient's physiology at the moment is holding. So once we are happy with the primary survey, we would add some of the investigations that are augmenting primary survey. So an ultrasound in terms of the abdomen as well as the chest. We will do the chest X-ray and the pelvis. But certainly this patient physiology seems to give us enough reserves that once we've done that secondary survey and the adjuncts, unless we find something really worrying on the case, we'll be preparing this patient for an investigation as in a PEN scan, because he will benefit from investigation of the head as well as the rest of the abdomen and the chest and the lower part of the limbs, as it has been stated already.
Dr. Solomia.
Here in Ecuador, we maintain in the trauma bay and continue the ABCD with ultrasound assessment and thorax and abdomen and X-ray about the thoracic and pelvis. Now I have a doubt about the injury in the head because has a obviously trauma in the head, and then thoracic pelvic. If I don't have any answers with the ultrasound, I move to the CT scan. We do a whole CT scan, whole body CT scan.
All right, thank you. Dr. Wang, go ahead, continue.
Okay, so in our facility, we also tend to keep our patient in our trauma bay, but I think this patient is relatively stable condition, so it's acceptable to let the patient to go to the the radiology layer to have some plain film, including chest X-ray and pelvic X-ray. But I think the other thing we can do in the primary surveys and add another EFAS. So if we perform the EFAS examination, we might notice that if there is absence of lung sliding or observe the barcode sign in M mode, suggesting a pneumothorax. If that's the case, we should probably insert the chest tube on the left side. And in addition, if EFAS is revealed intraabdominal fluid accumulation, we should immediately arrange further image, including CT, or if the patient have unstable vital sign, we will go to the operating room directly. We can also have quickly obtain a portable chest X-ray. It also can help us detect where if there's a pneumothorax or not. And after stabilization, the patient and finish our primary intervention, we will also perform a brain CT because maybe the patient have an initial loss of consciousness more than 5 minutes. So back to our patient, when I review the medical records from Kim Hospital, they actually did not perform the assessment exactly as we just discussed. Instead, because the patient had initial loss of consciousness and the trauma mechanism suggests a potential head injury, they choose to perform a brain CT to rule out any intracranial hemorrhage. Additionally, since the patient, her focus on her left hip pain and low back pain, so they perform a L spine AP and lateral view and a pelvic X-ray as their initial image study. And the brain CT was negative without facial bone fracture or intracranial hemorrhage. But the L spine AP and lateral views, there was no obvious lumbar spine fracture noticed, but we did observe some degree of kyphosis. Interestingly, on the LP AP view, I incidentally finding a rib fracture and a subcutaneous emphysema. And in addition, the pelvic X-ray revealed a fracture of the right superior pubic ramus.
Oh, can you hold on
So,
1 second? Can you hold on 1
yeah.
second? Dr.
Yes.
Solomir, in Ecuador, do you still do like a plain film LS spine, or is it go straight to CT and get a CT spine while the patient in the CT CAT scan table?
It is a very nice questions, but it depends the patient. If I need to take quickly decisions, I move to the CT scan. If the patient is very stable, I prefer use the ultrasound and then the X-ray, because my hospital is very busy and I have only one CT scan for all the hospital. Sometimes we need to priority what kind of patient go to CT scan.
It seems that waste a little bit of time here to do the spine. What do you think, Dr. Nguyen? What do you do in South Africa?
Yeah, so I agree with you. We would beyond the ultrasound and the pelvic X-ray, but we would not do the spine. We will do the CT scan, and in our PEN scan, we'll include all of the spine in this mechanism. So the C, the T, as well as the lumbar CT scan. So I agree with you. We would have not done the ordinary X-rays of the spine.
Dr. Prince, what is your routine in Cincinnati?
Yeah, we're very similar in that everybody gets a chest X-ray. We do pelvic X-rays actually selectively in people who are not going to have CT scans or people who are hypotensive. They'll get a pelvic X-ray looking for pelvic fracture if we can't pick one up on exam. And then off to the CT scanner and somebody who's reasonably hemodynamically normal. And we're spoiled in that we have 2 CT scanners that are 15 feet from our trauma bay, and we can walk over there very easily. So we're very fortunate.
All right, Dr. Wang.
Okay, so go ahead or yeah.
Yes.
Okay. So because of the L spine AP view incidentally reveal rib fracture and subcutaneous emphysema, they further arrange a contrast-enhanced CT directly. A contrast-enhanced CT shows left side hemopneumothorax consolidation in the left lower lung without obvious vascular lesion. Fracture of the left side ribs from the third to 12th ribs, which was a flare chest and also a spanning laceration. This was not a multi-phase or dynamic CT that including arterial phase image as a result, while we did also observe some hyperdense area within a spanning laceration, but we cannot conclusively determine whether they represent a vascular lesion or not. And after CT scan, they finally placed a chest tube for this patient. And here's the patient's initial lab data. They show leukocytosis with a white blood cell count about 17,000. The hemoglobin level was not significantly low at 11. There was a mild elevation in the delayed sign, but lactate level was normal, and the blood gas analysis did not indicate acidosis. So the initial after initial survey, the initial diagnosis including left traumatic pneumothorax, fracture from left third to 12 rib causing a flared chest, left lung contusion, grade 3 spleen laceration, and the fracture of the right superior pubic ramus. Management involving placing a left side chest tube, administering 1 gram of tranexamic acid, and provide a blood transfusion with 2 units of PEC RBC and 2 units of FFP. The patient was then admitted to the ICU for further care.
I'm sorry, can you stop here 1 second? So
Yes.
I didn't know from the CT, did you see extravasation from the spleen?
No, we only see some hyperdense, but this is not a multi-phase. So at that time, they didn't thought that was contrast ovulation or
let's do
Schindler reason.
something quick first. In terms of the chest drainage, would the panelist, anybody will put in the pigtail catheter or the conventional big open chest tube? Dr. Pritz.
So, even though literature really suggests that small bore chest tubes can be effective especially for acute hemothoraces, our local practice is small bore or pigtail for air. If there's a blood component, then they get a slightly larger bore, usually a 24 French chest tube.
Dr. Solomir, what do you do in Ecuador?
Chest tube, if I really know, is a pneumothorax, 28 French for drain.
So we would not do a pigtail catheter?
No, in the emergency, in the trauma bay, no.
Dr. Nguyen.
Yeah, we will also use a intercostal drain chest tube. We will reserve the pigtails for patients that are already well in ICU by that time. But in an ED, we are much more, especially with this mechanism, we would have gone for a chest tube, as it was said, either 28 or even sometimes a 30.
Okay, Dr. Wang, continue.
Okay, so the patient is now admitted to ICU. So we close monitor her vital sign, the chest tube output. We also need serial follow-up lab work, including hemoglobin, platelet count, PTA, PTT 500, and related marker. And she has a spleen laceration. It might also be beneficial to monitor intra-abdominal pressure. However, the interesting issue here is the flared chest. I believe we should consider surgical stabilization of the rib fracture because that was a flared chest. The key question is what's the ideal timing for this procedure, and should we repeat image study before moving ahead with surgery?
Yeah, Dr. Nguyen.
Okay, so maybe let me just say one thing before I answer this question. So for us, in terms of the question around the spleen, we would have run not only the arterial phase plus the portovenous phase, and that will help us to tell if there's a blush or not in the spleen. But coming back to the question that has been asked here, and by the way, the ultrasound, if there was no sliding, it would have been enough for us to insert an intercostal drain. But coming back to the question about stabilization, we want to stabilize in our environment, to stabilize them early, provided there are no contraindications. So in the absence of a major bleeding, in the absence of severe head injury, in the absence of anything else that worries us, the earliest possible time that we would like to do them is within that 48 hours. And the ones that are more complex will be the one where the other priorities are optimized before we stabilize the chest. So we like doing them a little bit early within that 48 hours if the patient's hemodynamics and there are no other priorities that are contradictory to the fixation of the chest.
Dr. Solomir.
In this case, I am worried about the abdomen. I need to resolve if I need to do a laparoscopic, for example. And about the thorax, we wait about 24 hours looking for the physiology. If the if the physiology don't work or don't is enough for maintain the oxygenation, maybe talk with the thoracic surgeons to fix the ribs.
And Dr. Prince.
We'd evaluate, as soon as the patient's stable, typically next day or day after, would go to the OR for rib fracture stabilization.
Okay, I have another quick question for the panelist. I think the AAST guideline suggested strong consideration of embolization of the splenic injury when the classification is 3 or 4. So on this patient, she has a grade 3 splenic laceration. Would you just regardless take the patient to the angio suite and perform embolization? Dr. Salomir?
I can't. I don't have embolization for these kind of patients.
Dr. Pritz?
We in our practice here, a stable patient with a grade 3 would be watched. If there's concern for a pseudoaneurysm, we do a follow-up CTA on day 4 or so, then embolize the pseudoaneurysm. If they're unstable in our institution, they get a splenectomy.
So you follow up a CTA in day 4?
Day 4 CTA. Correct.
Even the hemoglobin stable?
Even if hemoglobin, if they have active extrav or we're concerned about a pseudoaneurysm, all 4s and 5s in our institution will get a
Okay,
CTA.
Dr. Moen?
Yeah, again with some restraints with resources. In the absence of a blush, and I'm talking grade 3, in the absence of a blush for the grade 3, we'll just observe them for as long as they are doing well. We may not even do a follow-up scanner in a grade 3. Total different approach if it's a grade 4 or 5, in which case we might put in a follow-up scanner. But we will look carefully at the features on the scanner on arrival, looking at 2 faces so that we don't miss anything. But grade 3, we just observe in the absence of vascular involvement.
Okay, Dr. Wang, we have another 8 minutes.
Oh, sorry.
No,
So
Go ahead.
so we're also trying to do the similar thing on the day after the injury on the 9th of January 9th. We trying to actually the doctor in Kinmen trying to do the refixation, but he trying to follow our CT because of 2 reasons. One of the reasons is that the initial CT was a chest CT, so it's not involved in including the whole abdomen. The patient also have pelvic fracture. There might be a contractualization in the pelvic region or any vascular lesion, so he wants to make sure there's no other injury of the abdomen. And the other thing is that the initial CT is not including arterial phase. So repeated CT might help we identify a small aneurysm in the spleen artery. And fortunately, we did a follow-up CT, and it turned out there's actually identified a pseudoaneurysm is in the left lower lung. And also, we also find and suspect AV shunt in the upper pole of the spleen and the pseudoaneurysm in the lower pole. So, consider this finding. I think embolization for the spleen lesion should be performed because it can help reduce the rates of delayed conservative treatment failure and increase the chance of preserving the spleen. And for the left lower lung pseudoaneurysm, we have 2 potential approach. One is embolization alone. The other one is a combined strategy of surgical stabilization along with wedge resection of the lung lesion.
Dr. Moen, what would you do?
From where we are, number 1, as I've said, for us, our grade 3s, if they're doing very well and there's no vessel involvement, we would not worry the spleen. But I need to emphasize something important. We would not, with this mechanism, just do a CT chest. We would have done the CT brain, the whole spine, the CT chest, the CT abdomen, and the CT pelvis at the first setting, which would have been a little bit helpful. I just want to emphasize that. From the chest point of view, I think in the absence of ongoing bleeding, we would have sorted out the ribs. And when we are doing the ribs, we will see how much more bleeding we have inside and only then attack the lung. So the lung at the moment, in the absence of ongoing massive hemothorax, we would not do much to it other than the chest cavity itself.
Dr. Samaria, what do you do in Ecuador?
If I have worry, I do a laparoscopic for the abdomen and look. In this case, we only need to drain the blood in the peritoneum and maybe doing something for hemostatic in the spleen, nothing else. And in the thorax, the same. If I worried about that, I doing a video thoracoscopic to check the lung and decide if I need to open the thorax.
Dr. Pritz.
We probably approach each pseudoaneurysm with embolization first, and then surgical extirpation if that fails.
All right, Dr. Wang. So what do you do?
So we try to embolize for both the lesion. So because this last small island, the doctor radiology cannot perform embolization there, so the patient was transferred back to our hospital at the same morning of the examination. And when the patient arrived, the first procedure performed was splenic artery embolization. The major laceration is in the upper pole and some vascular lesion here. So we do a selective and non-selective embolization, and after that, there was no further vascular lesion being seen. And on the second day, a pulmonary angiogram was performed via left pulmonary artery. The angiogram revealed pseudoaneurysm at left lower lung segmental branch of pulmonary artery, and this one shows better. And the pulmonary artery embolism also, pulmonary artery pseudoaneurysm also been embolized. Okay. And after the procedure, the patient was transferred to general ward, and after that, the patient's clinical becomes stable, and the patient, in the end, she didn't take a rib fixation surgery because after discuss with him, he thinks her pain can be controlled by the nerve block. So at the 21st January 20. We also do a follow-up CT, and there was no new vascular lesion. And the patient was discharged on January 24th, and 2 weeks after initial trauma. And the final diagnosis for this patient is as follows: that left third to 12 rib fracture with left hemopneumothorax of left lower lobe with pseudoaneurysm formation, state post tube thoracostomy and embolization, and spleen laceration with pseudoaneurysm state post embolization, and left acetabulum and right pubic symphysis fractures.
I have two yes or no question for the panelists. Number one, would you perform a follow-up CTA? Number two, would you give the patient vaccination because you embolize the spleen? Then we'll start with Dr. Pritz.
No, and no, based on most of the splenic tissue is still there.
Dr. Nguyen.
Again, we also will say no, especially if we've done angioembolization. There's no need for a follow-up scanner in the absence of symptoms. And then no again for the second question about immunization.
Dr. Solomir.
In this case, I don't have the arterial embolization, so I don't have experience in next.
All right. Dr. Wang, anything else? That's it, right?
Yeah, that is the case.
Any pearls of wisdom from the panelists? Wrapping up. Dr. Nguyen.
Yeah, again, I think it's a lovely case that shows combination of injuries. They need to prioritize. My only humble suggestion would be a PEN scan from the beginning. If the mechanism is this mechanism that involves different regions, there's a lot more to gain from scanning both the head, the brain, the chest, and the abdomen and the pelvis at the same time. I'm going to leave it at that, but good outcome for the patient, and we congratulate the team that was assisting this patient.
Dr. Salamir.
Very nice case. In this, we can see how can help if you have angioembolization because you keep the patient outside of the operation room.
Thank you. Dr. Pritz.
Operating is not necessarily failure, but avoiding the complications of operation are always good.
All right, thank you so much, Dr. Wang, for your excellent presentation and for the comments from the panelists. So Dr. Mendogozo, you're gonna do the second one.
Sure.
Thank
Thank
you,
you
sir.
very much. Thank you, Dr. Gu. Thank you, Dr. Wang, for presenting the case. And it's my honor to present Dr. Gerd Daniel Pust, who's a professor of surgery, director of surgical intensive care unit, and associate program director at the surgery residency program from the division of trauma and surgical critical care, the Witt Daughtry Family Department of Surgery, Ryder Trauma Center at the Jackson Memorial Hospital, University of Miami. Dr. Pust, please feel free to start whenever you're ready, and I'm sure we're going to have a very interesting discussion.
Thank you so much for the kind introduction, and I would like to thank the Pan American Trauma Society and AAST for the opportunity to present this case. We had this patient a couple of weeks ago here in Miami at Ryder Trauma Center, and the management created quite some controversial discussions in our morning sign-out. So Dr. Matas asked me if I can share the case here with you for further discussions. So straightforward, this is a 32-year-old female who presents with a stab wound to the left chest. The knife is in situ and arrival at when the patient arrives. Primary survey, airway is patent. She does have bilateral breath sounds, and she has 2 plus palpable pulse. And you can see here that she's tachycardic with a heart rate of 120, blood pressure of 110/89, and she's a Glasgow Coma scale 15. She's awake. On the secondary survey, you can see that there's a knife in situ at the left nipple, and I have an image here. There's no other stab wounds, no other injuries, just this isolated penetrating trauma to the left side chest. And to make it a little bit more exciting, I have also a video, and it shows you that the knife is pulsating with the cardiac rhythm, even raising your concerns. So with that, I would like to open it up to the panelists and ask, what should we do here? Should we go immediately to the OR and do a thoracotomy, or should we go straight to the OR and do sternotomy? Or should we go a little bit less invasive and go to the OR and say, okay, what about we do a pericardial window, rule out a cardiac injury, put a chest up in, see if there's bleeding, and then remove the knife and look for bleeding into the chest tube and only do an open operation if there's ongoing bleeding after knife removal? Or what about VATS? What about just put a camera in and look what's going on here? Or do you feel like we should slow down a little bit and have time to do further imaging, doing a fast exam, maybe a chest x-ray? Do we gain anything by that or not? Will it change our management? Or does anybody even think like maybe to do a CT scan and see where this knife is located? Remind you again, the heart rate is 120, so she's not 80, but she's also not in profound hemorrhagic shock on vital signs. So how would you approach this?
That's perfect. Let's start with Dr. Salamia from Ecuador.
In this case, I moved to the operation room as quickly as I can. And I decided to do a lateral thoracotomy because in this case, I am afraid of the laceration, the anterior wall, and worried about the posterior wall because it looks better with a sternotomy. But in this case, I am afraid of if I have a posterior lesion, it's difficult to resolve from sternotomy. So I prefer a lateral thoracotomy.
Great. What about you, Dr. Pritz?
Similar, and I think it's dealer's choice a little bit whether sternotomy or left lateral thoracotomy, and if you choose wrong, you end up with both. And we actually have a patient on the service right now that unfortunately had that from a penetrating injury to the box. The sternotomy didn't work, and so ended up with a clamshell thoracotomy on top of that because you can't get to the posterior mediastinum particularly well through the immediate sternotomy. I think fast is easy and free, and there's no reason you can't faster as you're sitting there in the trauma. But if you got time enough to take a video, you can take a fast and at least get a sense that there's tamponade, if there's blood in the pericardium. This may be cardiac adjacent and sitting in the pericardium or even sitting in the hilum of the lung, where you don't have a penetrating cardiac injury. You probably don't have an injury to the LV just based on pressure. If you've got penetrating injury to the LV, you'd have tamponade or you'd have significant hemorrhage. So you could have RV, or you could have pulmonary hyaline based on that.
Perfect. Dr. Wang, any thoughts, any different thoughts in
No.
Johannesburg?
Definitely not. This patient needs theater. We will be comfortable because that injury is more to the left side of the chest, although it's central. We will be very happy with the thoracotomy. We would not waste any time. An ultrasound in ED won't delay an extra 2 minutes in our hands. So we would have no problem with it. But the rest of the other investigations at the moment are not going to add any value. So prepare for theater. Let the team be ready to go to theater. And then it will clean up the chest and do thoracotomy. And if for whatever reason we can't see enough, we will extend as needed to the other side. But thoracotomy should be enough for this patient.
Perfect. Dr. Pust, it seems everyone is excited to get this patient to the OR.
Yeah, and that was also the consenting on our morning sign out, that this patient should go to a fourth thoracotomy with no further delay. And that is certainly what probably the standard of care is and what's in the guidelines. We're dealing with a penetrating injury in the box. However, I decided to go ahead and do a fast exam first because I wanted to know if there's any ultrasound evidence of tamponade. Right? Typically, when we see blood in the pushing onto the right ventricle, we see tamponade physiology, and she was tachycardic. But she wasn't necessarily hypertensive. Now, the ultrasound did not show any signs of tamponade. I couldn't tell for sure if there's not a little bit of fluid in there. And also to remember, you can have, with pericardial violation, you can decompress into the left chest. And with that, you may have a false negative fast exam. So it does not rule out a cardiac injury in that scenario, right? I did do a chest X-ray as well. I'll tell you in a second why. I wanted to see if there's a major hematothorax or not. And you can see here the position of the knife, and you see that there's no major hematothorax. And the reason why I did that was, I originally wanted to call this case, thinking outside the box while in the box, but then you give things away a little bit. But the thinking behind was, okay, if the patient is in tamponade, straightforward open thoracotomy, no question, right? If there's a large hematothorax, signs of that there was major bleeding into the chest, straightforward left, thoracotomy as mentioned prior. But what if we don't have that, right? If the FAST doesn't show anything of tamponade and there's no major bleeding into the chest since she wasn't hypotensive, maybe we could consider to do a less invasive approach in this case. And what would be the option to do a less invasive approach? So we went to the OR after that, and with the following thinking. I was thinking of treating this patient as she has a cardiac injury or could go in tamponade at any time and be ready for anything, right? So we did the standard what we always would do. We would prep first and then induce general anesthesia and then look if her hemodynamic status changes, right? If on induction she becomes hypotensive, immediate open thoracotomy versus sternotomy. However, if she maintains her hemodynamic status via an anesthesia, could we do something less invasive? And what would both those two less invasive options be? One would be a pericardial window. The advantage of that, we can quickly rule out a cardiac injury. You don't need to set up a laparoscopic tower. And you feel much more comfortable. And then you could think, put a chest tube in and maybe pull the knife and look for bleeding into the chest tube and do nothing else. The downside is we don't see potential other injuries, right? What other injuries could be, as mentioned before, hilar injuries of the lung injury. What about the diaphragm? And what about bleeding from the tract when you remove the knife, right? So the other option would be to do a VATS, put the camera in and see where actually the knife is. No, this is certainly a little bit outside of what we normally do, but sometimes you have to push the envelope a little bit if you feel like there's a safe way to do it. And the safe way to do it is to be fully prepared and assume she has a cardiac injury and not just saying, we're going to take a tower, going to take a look, and then if we find something, now we start opening trays and delaying things, right? So that was the thought process. So what we did is we did a 2 centimeter skin incision at the fifth intercostal space at the mid-axillary line, just as where we would put a chest tube. And we went in and we put a Hassan cannula, and then I asked the anesthesiologist to right main stem the endotracheal tube so we can go on single lung. Ventilation and introduce the scope without insufflating air, because I didn't want to pressurize the chest and put air in case of she does have an injury and cause a air embolism. And then here's the video what you see. So you can see the knife right there, the tip. It's kind of guarded by the rib. You can see that the heart, there's no evidence of any fluid below the pericardium. We're looking over here, there's no laceration of the pericardium at all. I shortened the video a little bit, I cut it together. We looked fairly carefully. You can see the diaphragm. We did not see any injury in the diaphragm. There is some hematothorax from blood, which was dripping down from the chest wall. We did not see any lung hilar injury or anything else. And then we looked again up on the knife right now. You're going to see in a second where it's positioned. And you're going to see again, it's kind of guarded by the rib. So it didn't go as far in as it looked like from the outside. There's the tip. And now we're pulling the knife under direct vision. And you will notice that there is no major bleeding from the knife track from the chest wall. There's the knife. And we observed it for a while. And that basically what it showed. No other injuries. That's the specimen. And obviously, we have to evacuate the hematothorax. And there's two options. One is putting in another trocar and suction out the blood. We opted to just remove the Hassan cannula and use the Yang collar to suction out the chest, irrigate the chest, and then put the Hassan back, put the camera back in and look around. And then observe lung expansion and place the chest through the same incision, and that was it. So she did well because she didn't have any major injury, and we were able to avoid a major incision. And the patient was basically extubated post-op and was ready for discharge and had a very brief hospital stay. So for the panel discussion, again, obviously, we were right aware that we were a little bit pushing the envelope here. The question is, do you think it was a safe approach? Or you think we pushed it too far? Number one. And then number two, again, the discussion always what approach, right, when you have a cardiac injury. So let's say you do a pericardial window, it's positive. Do you do sternotomy versus thoracotomy? And maybe each of you can say what you do under what circumstances and why. And then if we have some more time, we can talk about the South African experience with having a positive window and irrigate and not necessarily open the chest on everybody. So maybe Dr. Wang can comment on that as well.
Great. So let's start with Dr. Pritz. I'm going to leave Dr. Wang for the comments as a third person to comment on the positive FAST as well.
Yeah, our default in general is going to be sternotomy and injuries inside the cardiac box and thoracotomy for either angles or outside. Again, limiting, knowing that you're limited to get to the posterior mediastinum and limited to get the lower lobes of the lung. And so we'll generally use those approaches. The thoracotomy for almost all of us is faster just because in our institution, we do those much more regularly than sternotomies. But if we're pretty sure we're just in the box, then we use a sternotomy. We will perform a window if the patient's hemodynamically semi-unstable or quasi-stable, you can call it. We'll bring them up to the operating room and do a window under local to at least resolve the tamponade prior to proceeding with incision. If they are stable and we have a positive window, we will irrigate and occasionally then leave a drain if we're convinced that there's no further bleeding and we don't have anything else in play. So we will follow that approach. Approach to coronary injuries, hope that they're distal and sew around them as best you can. And if they're proximal, they may need bypassed. And we're fortunate enough to have a group that will help us with that in those situations. But they're tough.
Great. Thank you. Dr. Salamia?
Very nice case and show we have to think in the thoracoscopy, look and then decide. My comment will be in this case is a positive or we have a heart injury. I think it's the best to decide quickly to go to the thoracoscopy to thoracotomy, because if have a heart injury, we need all of seconds we need, because in this case it's a different, because you have a stab. Yes, you have the knife there. Usually they stop the bleed. but it's different when you have without of the knife in this case, and the management will be different. But when you take out the knife, you have a quick, small time to resolve. I recommend the thoracotomy because if have a posterior wall lesion, it's very difficult by sternotomy to make stitches.
Awesome, thank you. Dr. Wang, what about your experience?
This is a very fascinating case. I think it's breaking all the rules in a nice and a beautiful manner. It's an unusual case. It's a patient who's young, whose physiology at least allowed them to be able to sustain the insult. And I think one of the issues that, for me, that it will highlight is that one has to be careful about young people because sometimes they will mask the extent of their physiology. So hopefully the ABG and the lactate levels were in keeping with the normal perfusion state in this case. Otherwise, if it was way off, we would have erred on the side of surgery. As I have said earlier on, we always figure out, is it just the mediastinum we are worried about, or is it the mediastinum plus the lungs or the lateral aspects of the lungs? The more lateral, the more happier we are with the sternotomy. The more mediastinal, the more we are comfortable with this. I mean, the more lateral, the more we are happy with thoracotomy. The more medial, the more we are comfortable with the sternotomy. Now, coming to the issue around the coronary vessels, luckily for us, or is it a self-limiting factor? Most of the cases that make it through are the ones that have got distal coronary involvement, and therefore we may end up with ability to let them survive, even if we are not able to repair those distal coronary areas. But the proximal coronary, the only way that you can pull them through, if they ever make it to your hospital, is to be able to put them on the bypass. What we tend to see most of the times will be injuries around the coronary vessels as opposed to on top of the vessels. The last comment that I will make is around the pericardial window. We follow a simple algorithm. If there's a lot of ultrasound fluid around the heart, if there's hemodynamic instability, that patient goes for a definitive surgery, which will be to either open the thorax or the sternum, depending on what the indications are. However, occasionally you find these patients that are doing very well. Usually they are delayed on arrival. Usually their physiology is normal. Those are the patients where an ultrasound, repeat ultrasound doesn't help us. We will then consider the pericardial window. The rest of the other cases, when they have evidence of cardiac involvement, we prefer to take them to theater. So only the stable, usually the delayed arrival, and those are the cases that you can talk about opening and seeing how much of the blood comes out and irrigating and taking it from there. So the South African experience, there's one center where they've got a lot of these cases that they've done. A lot of other centers are much more aggressive. Once they have blood coming in, especially in a patient that presents early and with some physiological derangement, they will automatically convert it to a sternotomy. But there is a room in a stable, well-controlled, delayed arrival of a patient that a pericardial window with a washout plus minus a drain, and the patient is managed in an ICU environment, that you are able to do it. So my comment to the group, I think this was a beautiful example of thinking outside the box in a well-controlled, well-staffed environment. It might not be duplicatable to other centers where the issues of thoracoscopy might not be available, and they have managed in the good resource environment to show how this envelope can be moved without compromising the patient's outcome.
Perfect. Let me just dig a little bit deeper in this subject, since we have some time. Dr. Pritz, let me ask you a question. If you do, in such case, if you did, for example, pericardial window, blood comes out from your window, you irrigate, and there's no further bleeding, would you consider not doing anything else, or would you still consider open the chest because of the blood that came out, the small amount of blood that came out?
Stable patient or unstable patient? Stable patient, we'd irrigate a few times, look around, probably bounce the heart with the Yankauer sucker a few times. And if we really don't stir anything up, we'd leave a drain in and close it for that. Unstable or continued bleeding, then they get an bigger operation.
Perfect. The same for you, Dr. Salamia?
The question is in this case or in the possible?
In the event of doing in such a case, but doing a pericardial window and then blood comes out from your incision, but the patient's still stable, you wash out the pericardial sac, and the bleeding, you don't see any more bleeding. Would you still open the chest?
No,
or would
no,
you
no.
just stop there?
We have a few cases, but we do the pericardial window and wash, and the water is clean, do anything more. Suppose the patient is stable, no?
It's perfect. Dr. Wang, the same thing?
Yes, as I've explained, I think for us, but I want to caution everybody. If you look at that, it has to be in a unit where there is good monitoring. It has to be a careful selection of the patients whose hemodynamics are normal. Then we can talk about it. And for us, most of these patients are delayed in arrival. The fresh trauma patients, you'll find very few of them where the positive blood around the pericardium equals to nothing major. So I'm asking that when we apply that concept of irrigating and washing and leaving a drain, we must make sure that the indication and the support to watch your patient and the availability of theater, should anything go wrong, should all be well aligned, so that you don't end up with a medical legal case of a patient that dies or succumbs after all of those investigations are done. I hope that answers it in a comprehensive manner, a careful selection of those that will have a positive pericardial window, and you are able to wash them and irrigate them and just put in a drain inside.
That's perfect. I think it's perfectly clear. Dr. Pust, did you want to add anything to this case before we wrap up?
Yeah, just to summarize, we were well aware that we were outside the box or thinking outside the box, right? But things develop in trauma, right? I mean, I remember when I was a resident or fellow, he came in with a penetrating neck wound, stab onto the neck, platysma was violated, everybody got a neck exploration, right? Now we only do it for unstable patients or heart science or vascular injury. Otherwise, they get imaging, right? We're doing much less neck exploration than 15 years ago. Same with laparotomies. 20 years ago, everybody came with stab onto the abdomen, got a laparotomy. No matter what, we learned there's a lot of false negative laparotomies, and we became much more selective in terms of laparotomies. This case is certainly pushing the envelope. We have to be careful what we're doing, and we have to be aware we're doing that. The circumstances here was as such that she wasn't hypotensive, that she was awake, that she, was tachycardic, which was concerning to me. But I felt like I had the time to do the fast exam on the chest X-ray, and that demonstrated to me that she did not have a major hemorrhage going on, right? Which doesn't rule out an injury because the knife could still be in position. The other thing what we noticed, by the way, I forgot to mention, is when the patient was like kind of 45 degrees upside when the video was made in the trauma resource bay. When we had it on the operating room table and we put it flat, the knife stopped bouncing, which was also kind of an indication for me that probably it's not sticking in the ventricle, but rather like, riding kind of against the pericardium. And the tower was ready, everything was ready, so it didn't get delayed. And therefore we decided to do what we did, well being aware that, certainly she could have an injury, certainly her physiology could change any moment. And we were ready for that thing. We had the trace open, we had the sutures open, the double arm proline open, we had the pledges ready. So everything was ready at the time of induction. So if there's any change, we would go back to our normal default approach. So when we do something like that, we have to have a high level of awareness that we, deviating a little bit what our normal standard protocols are.
Awesome, great. Before we wrap up, I see a question from Dr. Gu in the chat. I'll run quickly with you guys here about this question. So Dr. Gu is asking, what about doing a post-operative imaging test such as CTA despite the VOTS results? Would any one of the panelists do a imaging test post-operatively?
I think with us, the chest X-ray will suffice if there has been good observation as it was done here, and if there's no hemothorax that develops later, we would not do a CT angiogram. We'll be happy with clinical observation after all of this, the way that they looked at the patient, took their time in theater, waited after removal of the knife before they removed the camera. So that will be reassuring for us.
Perfect. Dr. Salamea, what about you?
Only see the tooth drain and X-drain plane, no more.
Perfect. Dr. Pritz?
Yeah, I think if you've seen the path of the knife and you're not worried about intercostals coming in and you're not worried about the IMA on that side, I think it's reasonable to just follow clinically with chest X-rays. If you're concerned about either, CTA is an easy thing to do, and again, in institutions that have access to embolization, that's a easy treatment without returning to the operator.
Perfect. Dr. Pust, did you do any imaging tests post-operatively?
No, no further imaging. I mean, it was pretty lateral as you saw in the video, so we're not worried about the IMA. One more question I have for the panelists, because that was going through my mind, is like, okay, you put the camera in and the knife did not go through the pleural space, right? In this case, it went through the pleural space. So by default, if you worry about a cardiac injury, the pericardium needs to be violated from the pleural side, right? So we would see it. But what if the knife was more medial and the knife could potentially go through the pericardium towards the heart without entering the pleural space, right? Would you, in that scenario, still add on a pericardial window, or would you be happy enough with looking with the camera through the pericardium, you see the heart moving underneath it, and that's it? Or would you add on a window if the track wasn't through the pleural space, but rather more medial directly parasternal, basically, extrapleural?
Perfect. Dr. Pritz, you want to jump in?
That's a tough question. I mean, if you've got a good view of the pericardium, even medially, you should be able to see if there's any blood sitting there at all. And so I think you might be okay if the knife came out and there really wasn't any evidence of bleeding. I think probably sit on it. I think your clinical observation that as the patient went to sleep and was flat, the knife stopped pulsating is actually a very profound one, and probably a good point for all of us to sort of take home out of this. And the question is, if the knife was still pulsing or there's now hemorrhage along the knife, would you proceeded with the VATS, or would you have opened at that point? But
would you consider to do a pericardial window laparoscopically through the pleural space? I've seen a presentation out of South America where they did it. Just elevate the pericardium and took a scissors and actually opened it laparoscopically through the pleural space. Or would you go old-fashioned pericardial window?
Yeah, I think that's you're sitting there, and if you've got the angles and you've got the skill set and you've got the visualization, it's a fairly straightforward thing just to open the pericardium a little bit laterally, and that way you can even potentially inspect the heart doing that, although I have not done that. But if anything is not all lining up, if the stars are not aligning, so to speak, then you default to subxiphoid window and coming through that direction.
Perfect. Dr. Salamea, do you agree?
I think if everything is quiet, you can do a pericardiostomy by thoracoscopy. But if you start to bleeding, you have a quick seconds to doing something. In this case, if I have blood, I prefer lateral thoracotomy because it's more quickly to assessment.
No question about it. Same here.
What about you, Dr. Wang?
Well, now we might have gone a little bit less invasive, i.e. convert from a TEE, from a thoracic, to try and see if TEE also doesn't have fluid around. Therefore, if we didn't trust the ultrasound from outside and we didn't find anything obvious on thoracoscopy, I think we would just add a TEE on the table and not necessarily open. If TEE was not available, we know of cases where hemopericardium can be missed, and therefore you may want to open up. Not very easy from the thorax point of view, but it is doable as opposed to going through laparoscopic approach. But we would have asked for the TEE look better, have visualization, and if the thoracoscopy didn't show much and that didn't show much, then we will just be happy to watch that patient.
That's a great suggestion. Okay, thank you very much, Dr. Pust, for presenting, Dr. Moing, Dr. Salamea, and Dr. Pritz for being the panelists in this session as well. I'm going to defer this to Dr. Pascual to end the meeting. Thank you very much.
No, thank you very much, Carlos and Alan. I have nothing to add except thanking everyone who participated. And if there's anyone who's interested in presenting a case, you can see the cases may be of very different types from anywhere in the world. Please send that to Carlos, Alan, or myself. We are on the website. Thank you very much, everyone. Have a good rest of your week.
Thank you.
Bye, everyone.
Thank you.